welcome. Glad so many of you are here with us tonight. My name is Max Wolff. I'm a clinical psychologist and addiction researcher. I'm a member of the science department in the Mind Foundation. And this is the second episode of the Zooming In webinar series within the Mind Academy. The name Zooming In is supposed to convey the fact that we're having in-depth conversations with researchers and therapists involved in psychedelic therapy and neighboring disciplines. And at this point, it's time for a disclaimer. When we talk about psychedelic therapy here, we always refer to legal treatments that take place in a professional clinical setting in a highly controlled context. And we do not endorse unsupervised self-medication with psychedelics or the use of illegal underground therapies. So our guest for today is Rick Zeifman, who's joining us from Toronto. He will introduce himself in a few moments. And the plan for today is that I will have a conversation with Rick for about 60 minutes. And after that, we'll do a Q&A for half an hour, 30 minutes. Please use the Q&A button at the bottom of your screen for posting your questions about today's topic to Rick and me. And you can use the chat for technical questions, all kinds of comments, or just for chatting. And operating in the background today, we have Bas Minima. He's our technical host today. He will also post links to interesting stuff that is related to what Rick and I will be talking about, interesting papers, related events, etc. So yeah, please leave the chat open so that you don't miss any of that. Now it's my pleasure to introduce Rick Zeifman. Rick, great to have you here.
Good to be with you.
Rick, could you say a few words to our audience about who you are and what you do?
Sure. So I'm a PhD student in clinical psychology at Ryerson University in Toronto, Canada. My research, I also collaborate with the Center for Psychedelic Research at Imperial College London. And my research focuses on interventions for highly suicidal individuals with a specific focus on mechanisms of change. So really trying to understand how do such therapies work or why do they work? And more recently, I've developed a real interest in applying that kind of research to investigating could psychedelic therapy be useful for treating suicidal individuals, and also trying to understand when psychedelic therapy does work, how does it work? Why does it work? What are the mechanisms that lead to positive therapeutic outcomes?
Right, yeah. And that's just our topic for today, right? Psychedelic therapy for borderline personality disorder. Maybe, yeah, for some background for our audience, what is BPD? Or borderline personality disorder? Maybe we're not going to say the whole 3 words. Maybe we're just going to say BPD to make it shorter. What is it?
Borderline personality disorder, it's a severe psychiatric disorder. It's characterized by a range of symptoms. The kind of core symptom that people usually identify is emotion dysregulation. So difficulty controlling emotions, shifts between different emotional states that can be painful and challenging. That emotion dysregulation often goes along with a range of other symptoms. So behavioral dysregulation, people with borderline personality disorder tend to engage in impulsive and dangerous behaviors. There's also high rates of non-suicidal self-harm, suicide attempts, and completed suicide. So people with borderline personality disorder, it's about 8 to 10% of people with BPD will eventually die by suicide. And beyond those symptoms, there's also cognitive symptoms related to people's feelings or thoughts about themselves, as well as cognitive symptoms related to mild kind of disturbances in terms of one's sense of self or external reality. So depersonalization and derealization can often be present as well.
Yeah, thanks for that. That's a really concise sum up of BPD. Could you maybe give us like a more plastic idea of what the everyday life of a person with severe borderline personality disorder would look like?
Yeah, so one thing that's hard to do there is it's a disorder that has a lot of different presentations. So it's actually quite hard to identify for any one particular individual how's their BPD going to look. it's similar to something like depression, but with BPD, say you have in the DSM, you have 9 different kind of areas, and they have to have 5. So any 2 people with BPD can actually have very different presentations.
Right, yeah. Can be completely different combinations of symptoms. Right.
Yeah, definitely.
So there's no really like no prototypical case of a.
So there are attempts to identify prototypical cases. The question is how useful they are. Some things that you might say is this kind of intense emotional responses, often in the context of what research is starting to see is in interpersonal relationships or in interpersonal dynamics. So people with BPD often have intense fears of being abandoned. They might be evoked to anger or shame or intense sadness, often in the context of interpersonal interactions or relationships, but not necessarily. So if we could say anything about what the core is, it's this kind of changes in emotional states, sometimes with quite intense emotional states, and difficulty in kind of social functioning related to that.
Right. So borderline patients have quite turbulent relationships.
Yeah. So one of the features of BPD is that people's kind of meaning systems tend to kind of weigh in and weigh out, and that could lead to difficulties in relationships. If you think about how you relate to a person from one day to another, if it's not consistent what your feelings are or what your kind of meaning system is, it might be difficult to have kind of stable relationships. So that can be in some relationships. Sometimes people with BPD, it's kind of characterized by their romantic relationships. Other times it can be more globalized in the relationships. But there often is this kind of pattern of difficulty in relationships. And then another feature that's often present is due to this emotion dysregulation, this experience of intense emotional pain, there's often high rates of self-harm and suicidality. So the vast majority of people with BPD will engage in some kind of self-harm throughout their lifetime. Often it can be chronic, so things like scratching oneself or cutting oneself, things like that.
Right. Okay. And how is borderline personality disorder currently, or maybe let's look into the past a bit. So the term BPD or borderline is a historical term, right? It comes from like borderline between psychosis and neurosis. We don't say neurosis much anymore, do we?
We don't. So I'd say it comes from more psychoanalytic terms between they were identifying patients that had issues with neurosis, so kind of like extreme affective issues, and almost bordering on psychotic features. So people in these states of intense emotional distress with BPD can sometimes have the sense of depersonalization, derealization. They can sometimes experience kind of mild transient paranoia. So the label of borderline personality disorder was given to that as this kind of place in between people who have both a high level of neurosis and maybe something leaning toward psychosis. The term itself doesn't necessarily carry so much favor with everybody for a number of reasons. One, it's not so clear. So some people think borderline means like you almost have a personality disorder. One word that's the ICD considers it emotionally unstable personality disorder, which kind of is at least a little bit closer.
It's a more descriptive term too, yeah.
Definitely more descriptive. And then there are also concerns about describing borderline BPD as a personality disorder. So if you look at the range of symptoms, it does seem, and there's some research to suggest that it's closer to an affective disorder, like depression or like anxiety, of the more extreme case. So it more falls along the lines of an affective disorder. So calling it a personality disorder when it is something that is treatable is not necessarily the most helpful term. So it's kind of debate within the field.
Right, I see. Okay. And so how's borderline personality disorder treated nowadays? If you're lucky, let's say if you live in a country where there's good mental health care, what's the state of the art treatment for borderline personality disorder?
Sure. So people with BPD, it's important to note, they're about 1.6% of the population, but about 20% of all outpatient care is for people with BPD, and about 50% of all inpatient care. So they are definitely getting a lot of the treatment that exists goes toward people with BPD, but at the same time, there isn't sufficient care. So a lot of people with BPD aren't able to get treatment. When they do get treatment, there's basically two ways that it's treated. The first is pharmacotherapy. So antidepressants are often given, antipsychotics, mood stabilizers, and then there's also psychotherapy. So if we start with pharmacotherapy, the majority of people with BPD are prescribed medications, but one of the problems there is that there really isn't much research to support pharmacological interventions as reducing BPD symptoms. So some guidelines say we should never use pharmacotherapy to treat BPD symptoms themselves. If someone has depression, maybe we can treat that with it, but we shouldn't use pharmacotherapy to treat BPD. And some say maybe certain specific symptoms of BPD can be treated with certain pharmacological interventions, but that's kind of a debate. But at the same time, there are still high, as many as 90% of people with BPD and no comorbid disorders are receiving pharmacotherapy. And that likely suggests that physicians, psychiatrists are somewhat desperate to try to offer people with BPD something to try and help them. So the first line intervention, though, or what's most strongly recommended for people with BPD, are psychotherapeutic interventions. So let's say up to the 80s, the assumption was BPD can't be treated. There's no way to deal with it. There have been a number of evidence-based treatments that have been developed that have shown to be efficacious. So the most commonly talked about often is dialectical behavior therapy. Additional ones are what you might label under psychodynamic treatments, and those are mentalization-based treatment and transference-focused psychotherapy. There's also some evidence for schema-focused therapy. So these interventions have been developed over the last few decades and have been shown to be efficacious, which is fortunate. There's a few limitations with them. The first being they're quite intensive. So traditional DBT, let's say, is a full year, and it also has individual and group components, phone coaching. So the majority of people actually can't access these treatments.
It's incredibly resource intense, right? I mean, you have to have really skilled therapists who have a lot of time. And I suppose, how's it in Canada? I mean, is DBT available to most patients who need it?
I would say that it's not. There's really long wait lists. So people are constantly calling, trying to get a spot. Sometimes the only way to get treatment is to join a research study, which is, I think, ethically a little bit problematic. But if people can't get the access to the treatment, there are centers and clinics that do it. Oftentimes you have to pay, which is problematic for a number of reasons, especially given that people with BPD often do have a kind of low socioeconomic status. Not always, but there is a correlation there. So people, even though there are effective treatments, accessing those treatments can be quite difficult and complicated.
And that's one of the most developed countries in the world, where we have a good mental health treatment system, I would suppose.
Yeah. In general, I think Canada is pretty good when it comes to health. Mental health is a little more complicated. Things aren't as funded. But I'd say the population of people with BPD are probably especially underfunded and under taken care of.
Right, but it's fortunate that there are treatments nowadays. So you said it in earlier times, like in the 80s, BPD patients had a reputation of being untreatable. I would suppose that has to do with the fact that when you try like classical cognitive behavioral therapy, it really often doesn't work. Right.
So one of the reasons I think why there was this assumption that it doesn't work is that the presentation can be quite severe. And because of the interpersonal nature of the disorder, it can make it difficult to establish a therapeutic relationship or to kind of maintain therapeutic alliance throughout treatment. So although there was this assumption that it couldn't work, we are fortunate that there are evidence-based treatments for it. One of the issues there is the question of what exactly is an evidence-based treatment, right? So evidence-based treatment basically suggests that we know that it leads to reductions in symptoms. And I think one of the issues there is that, so we know that there are these treatments that work, but the question is, how well do they work? And who do they work for? So these treatments work for some people with BPD, but not everybody. There's lots of dropouts from these kinds of treatments. And even when they do work, the effect sizes aren't that great. So you get what's called a small effect size for changes in BPD type symptoms with even the frontline interventions like DBT. So it works, but it doesn't necessarily work to the point where you'd think that somebody who gets DBT now has symptoms just like any other individual in the population. So the issue there is, we have these treatments, but the rate at which they actually lead to remission from BPD, or the size of the difference after they finish treatment is not that large. So this tells us two things. One, that it is you can treat it. It is possible to treat it, but we need to do a little bit better in how we treat it. So sometimes we can get caught up in these labels of evidence-based without paying attention to, well, what does it mean to be evidence-based? And do we need to work harder to develop additional or alternative treatments that are even better than the ones that we can offer now?
Yeah, there's always the difference between statistical significant effects and clinically significant results, right?
Yeah.
I suppose that this leads us to our main topic, right? You wrote a paper, came out this year in the Journal of Contextual Behavioral Science in a special issue. So the JCBS, this journal is the flagship journal of the Association for Contextual Behavioral Science. That's basically the association of, well, they do more than that, but it's basically the flagship journal of ACT, right?
Yeah, of acceptance and commitment therapy.
Yeah. So Steve Hayes is the editor of this journal, and he even had a paper himself about psychedelic therapy and ACT or contextual behaviorism in this issue. So I highly recommend this special issue of the JCBS. And you had a paper there with a colleague, a theoretical paper called Exploring the Case for Research on Incorporating Psychedelics Within Interventions for Borderline Personality Disorder. What was your idea? What was your motivation to do that paper?
Yeah. So the basic motivation came from being kind of nested in research on treatments for BPD and starting to become aware of their limitations and this need. And when you see people with BPD, it tugs at the heartstrings. It's people in extreme distress, and so it came from this place of thinking about how can we make better interventions. And one of the ways that I started to look at that is doing research on what are called mechanisms of change. So that's really trying to pick apart what's going on within therapy that allows us to be able to see improvements in BPD symptoms at the other day. What are like the fundamental ingredients of treatment? And then as I was looking into that literature, I also started to come across some of the literature related to psychedelics. And it seemed quite promising in certain areas, and that started to intrigue me. So we have a pharmacological agent that in combination with psychotherapy shows promise for a number of quite difficult to treat disorders. Many of those disorders are highly comorbid with BPD. So I started to think about, is it possible that that using psychedelics within interventions for BPD could be helpful?
Yeah, and we should say at this point that to date there have been no systematic investigations into psychedelic therapy for BPD, right?
Yeah, that's right. So some of the early research, it didn't use terms like BPD, but they would, like people like neurotics or people with extreme affect issues with affect, So not necessarily what we would call a clinical sample of BPD, but there was a kind of description of people kind of fitting those kind of characteristics. But there weren't full studies of people with BPD, and also a lot of the early research was characterized by important limitations. So to date, there actually haven't been any full systematic studies done on BPD and psychedelics. There have been a few studies that might start to suggest that it could be useful. So there was one study where it was a randomized control trial done in Brazil where they administered ayahuasca to people with treatment-resistant depression. And 5 of the participants in the ayahuasca condition actually had BPD as well. So that's one study that might, and the results of that were quite promising for those 5 individuals. So it's a limited study, small number of people with BPD, only looking at symptoms up to 7 days afterwards, so very short term. But in all the participants, we found significant and large reductions in depressive symptoms, so in affective symptoms. And then there were also, in the majority of the participants of those participants at 7 days later, we find decreases in suicidality as well. So that's kind of one marker of maybe we have a treatment that could be helpful for this population. There's some other studies that also might be helpful for as an indication of its usefulness. So there was a observational study that was done with ayahuasca in a community sample, and a subgroup within that sample had what you might call BPD traits. So those are people that have some of the symptoms or some of the characteristics associated with borderline personality disorder, but don't necessarily have a clinical diagnosis of BPD. And what they found in that study was administering ayahuasca to those individuals led to reductions in emotion, in a few areas of emotion dysregulation, which, as I mentioned before, is kind of that core characteristic of BPD. So those are kind of a few suggestions that maybe there might be something here, but very far from anything that tells us that it is effective or that this should be a treatment for BPD.
Yeah, that's the way I read your paper too. Is like instead of looking at disorders, like decomposing borderline personality disorders into its main aspects or in the main symptoms, and then looking at empirical and theoretical ideas why these areas or these symptom clusters should be or could plausibly be treated by psychedelic therapy.
Yeah. So that I think because there was so little, there's only those few studies, and some of those weren't actually even published when I started writing the paper. But because there was so little, I wanted to see, okay, beyond just this concept of someone having BPD, how else can we try to answer the question of whether we might think it would be helpful? And because I'm a mechanisms researcher, I started to look into like what are the kind of either symptom clusters or the underlying mechanisms within BPD. And so what BPD is often characterized as having kind of 4 distinct domains. One is emotion dysregulation, a second is behavioral dysregulation, a third is relationship with one's sense of self, and a fourth is social functioning. So I wanted to look at those different 4 clusters to see, well, if we think of this not as one unitary diagnosis, but actually as a presentation of a number of symptom clusters, what information can we pull from the research that already does exist on whether or not psychedelic therapy could be useful for people with BPD?
Apart from the fact that, psychedelic therapy is often referred to as a non-specific intervention, or as something that treats some kind of a common core of a large variety of different psychiatric disorders.
Yeah, so I think maybe because there's been all this research both in healthy individuals and across a wide range of populations, there has been this kind of theoretical suggestion that maybe the best way to think about it is that psychedelics target something underlying affective or mental health concerns. And this is kind of consistent with a lot of the research in psychotherapy itself, which is moving away from a pure focus on a disorder itself and more looking at what are the processes, what are the underlying mechanisms that explain the presence of the disorder and that help to treat the disorder.
Okay, now looking at these mechanisms or these individual clusters of symptoms individually. So you mentioned emotion dysregulation as one or maybe the core symptom of borderline personality disorder. So what do we know about how psychedelic interventions affect emotion or the ability to regulate one's emotions?
Yeah.
Or what is emotion regulation anyway, in a sentence?
Yeah. So it's a multidimensional concept. You might think of it as relating to both one's experience of emotions, one's ability to understand and make sense of emotions, and also one's ability to regulate or to control the emotions when they do present themselves. So what we know about the impact of psychedelics on emotion dysregulation comes from a number of studies. The first one was one I already mentioned, which found decreases in components of emotion dysregulation, specifically emotional control, which is that ability to regulate one's emotions, and acceptance of emotions, so that that dysregulation decreased after ayahuasca. So that's one interesting but small study. One area that we could look to is that emotion dysregulation incorporates what we might call affective symptoms, so your emotional experiences. And there are a good number of studies that in different populations have looked at the impact of psychedelic therapy on affective symptoms. So we have a number of randomized control trials among people with cancer and death-related anxiety and distress. And in those populations, we find that after psychedelic therapy, there are large and sustained reductions in affective symptoms. We also have an open label trial using psilocybin for people with treatment-resistant depression, found similar results, as well as the same for a randomized controlled trial looking at that among people with treatment-resistant depression with ayahuasca, and also found similar results. So I'd say it's limited in the sense that we don't know that this would necessarily help with affective symptoms or emotion dysregulation among people with BPD, but it's at least somewhat of a signal of the fact that there might be something that psychedelic therapy is doing to the emotional system that could be helpful in the context of BPD. And this brings up that what we discussed earlier, which is this idea that BPD may be better conceptualized as an affective disorder. And if that's the case, it's really important to look at, well, what are the impacts of psychedelic therapy on other affective disorders? Sure. And what we're finding so far is that the results are highly promising. So still only a few studies, still small for the most part, but the results are nonetheless highly promising, especially in comparison to other kind of frontline interventions and their effect sizes.
Maybe to take a step back again, how would you characterize the relationship that BPD patients or people severely affected by borderline personality disorder, their relationship to their own emotions? How do they view emotions? How do they relate to them? How do they treat their own emotions?
Sure. Yeah, so I'd say one of the characteristics is this sense of, so the emotions are often highly distressing. And one of the main things that treatments will often look to target is not necessarily the emotion itself, but how do people relate to the emotion. So this is where concepts like mindfulness get introduced, especially within something like DBT. I think mentalization-based treatment is doing something very similar. Basically, you're looking to shift the way in which people respond to or react to their emotions. So if you think of a distressing emotion coming up and then they're resulting in non-suicidal self-injury, what's going on there is a reaction to the emotion, this unwillingness or not wanting to remain in contact with it. And so using some tool to regulate that emotion, whether it's substance use or self-harm or even suicide. So what we find is that there are low rates of acceptance of emotion. So there's a strong tendency to want to run away, distance from these emotions, and that's actually what is a main target of therapies, is to see if we can, if the skill of being able to sit with a distressing emotion can be increased.
Right. Yeah. I remember a supervisor of mine, a psychotherapist, a teacher, who referred to BPD patients as emotion phobics. Would you agree with that in some way? Like responding
Yeah.
avoidantly to emotions, or being scared by them?
Yeah. So I don't know that I would use the term emotion phobic. I think there's a combination of things that is going on for people with BPD. So I think they both are having intense affective experiences, and there's a response of not wanting to maintain contact with them that's perpetuating a bit of a cycle. So I would be hesitant to say emotion phobic, because it makes sense on some level that if someone has that intensive an emotional response that they want to push it away. It's more, I think about it as like, given that that's the case, how can we shift the way that you respond?
That's very, very insightful, I believe. Considering the fact that even people like you and me, who as far as I know, have normal emotions. Even for us, it's sometimes really hard to embrace them or to accept them. So like imagining how it must be to have really strong emotions that have a faster onset, grow much stronger, and stay much longer. It's harder. It's especially hard for those patients to learn an accepting stance, I'd imagine.
Yeah, definitely. I think, and that's one of the things of being in contact with so I think that the population itself can be highly stigmatized, and sometimes that comes from interactions, like challenging social interactions. But I think I spent a lot of time doing assessments for people with BPD, and also specifically assessing their self-harming past. And there you really get a sense of like just how much emotional distress people are in. So you start to understand that it almost makes sense that there's this unwillingness or not wantingness to remain in contact with it. So I think like the most helpful way of responding to that is to, and this is maybe comes from also a DBT perspective, is to validate that. Like that actually makes sense, that one might want to cope with one's distress by doing something that distracts. At the same time, the question is, what's the most pragmatic way of dealing with the emotion when it is present? And one of the kind of main tenets is basically two things. One is one's ability to distance from the emotion on some level, so not to avoid it, but to in like a metacognitive way, or to decenter, or cognitive diffusion. All these different models have very different ways of describing what is probably the same phenomenon. So one's ability to not be totally absorbed by the emotion. And then the other one is this element of acceptance. So to what extent can a person develop a skill of not necessarily liking or being comfortable with the emotion, but sitting with it and allowing it to be there.
So there is a fantastic qualitative paper. There's a few qualitative papers that have been conducted within psychedelic research, modern day psychedelic research. And one that I like particularly is Rosalind Watt's paper on acceptance and connectedness in psychedelic therapy. So these were the two themes that she found in a lot of patient reports from psychedelic experiences in a psilocybin for depression trial in London. And I highly recommend reading this paper and reading all the statements of patients. So when you read this paper, you get an idea of how patients change their view on emotions from something scared and fearful to a state of, you can almost say maybe tenderness towards your emotions. um, I don't think acceptance. I think acceptance sometimes sounds a bit misleading if you don't know how it's defined in in the
Right.
literature, or if you use the colloquial meaning of it. So yeah, what I the word that fits best when I read those reports in this study is actually tenderness.
Mm.
I don't know how you feel about that.
Yeah, no, I really like that. I think the word acceptance can mean a lot of different things. It can have a kind of cognitive component to it of like, I accept the things that are happening. It can also have a sense of like, I'm not going to run away from them. But I do think that sense of turning towards one's own suffering and meeting it is a really important part of psychedelic therapy and of what acceptance means. There was a years ago, I heard Bill Richards. He was giving a talk, and he one of the things that they suggested to their clients that always stuck with me was during the session, if you see the snake, go in through its mouth and look out through its eyes.
Mm.
So the idea is that usually when we see parts of ourselves that are distressing or scary, we want to run away from it. And the problem is that it ends up being kind of like a tornado. If you're running away for a tornado, it's always going to be approaching you. You're never going to get out of its wake because it's still a part of you. It's still inside you. And this
Right.
idea that instead of running away, we actually go into it and we try to pull out from it. What can we learn from this thing? And even just recognizing that there's this part of ourself that, is probably there for a reason, is probably a function to that fear, it probably or sadness. Like I'm sure at some point in life it had an adaptive function. And I think the more that, and I think the research is starting to suggest that and bear this out, that the more that we can face those things and actually learn from them as opposed to run
Mm.
away from them, the more we can both cope with the emotions that are there and maybe in the long term actually decrease
Mm.
those emotions as well.
Yeah. Another term that comes to mind when you explain this is self-compassion. I know that this is a one of the core elements of DBT too, and of many schools of mindfulness practice.
Hmm.
Um, when you when you were talking about this tornado thing, is trying to get away from it, but you can't. Are we getting close there to what actually happens in psychedelic therapy that makes people accept emotions, or try to find a different way of dealing with emotions than running away from them?
Yeah. So I think it's a really good question. That kind of what is the mechanism of psychedelic therapy is kind of the bullseye or like the important target that we're trying to figure out now at the moment. There's a number of different suggestions as to what it could be. My research actually does focus on that question of to what extent does psychedelic therapy allow us to shift from running from our emotions to actually accepting them, which is basically comes out of that paper that you mentioned before. I think that it's likely that it's an important element. So I think there are a lot of different theories about what's going on, but I think the data so far do suggest that one of the things that's going on is that whereas when we're in our regular awakening state, we have this ability to decide what we want to be in touch with, and we have the ability to kind of in a top-down way push away things. What a psychedelic does is really almost unravel that pattern and basically makes us face whatever is going on inside us. And those are those old theories of that, like when you take a psychedelic or when you're training someone to be able to take psychedelic in therapy, that you want people to just let go. And that there is something perhaps very powerful about facing one's demons and not only facing them in the moment itself, but maybe taking that with you as you go. So I think at the moment there's a lot of focus on what happens in the psychedelic experience itself. But I would imagine that one of the things that might be important is not just what happens in the session itself, but what that teaches you. So if you have a psychedelic session and you are open and accepting in the moment, but then afterward you kind of shift back to running away from your emotions, I'm not sure that that's going to be something that's going to be sustainable in its effectiveness. Maybe a week, maybe two, but I think one of the areas that needs more attention is really this kind of integration piece. So how can we take that experience itself and continue to manifest it afterward? And I think that acceptance piece was one of the main things that actually pulled me into thinking why psychedelic therapy might be helpful in BPD. Lots of research suggesting that acceptance and mindfulness generally, is a mechanism. So it's correlated with change. It also leads to change temporally. So this is suggesting that one of the reasons that therapy is effective is because people shift from this sense of running away to remaining in contact with their emotions. And in psychedelic therapy, the fact that it seems to be a catalyst for this, it seems to make that possible, or make that almost maybe even force you to do it, I think might be one of the reasons why it's efficacious in general, and why integrating therapies that focus on acceptance and psychedelics, which seem to allow one to experience one's emotions and be tender toward them, as you said, might be helpful. And that was actually a big focus of that special issue that came out in JCBS.
Yeah. Oh, we should mention at this point that there is an emerging literature now that suggests that the relationship between psychedelics or psychedelic use or psychedelic therapy and mindfulness and acceptance is kind of a reciprocal one, in the sense that psychedelic experiences appear to enhance mindfulness capabilities or acceptance, and at the same time having a mindfulness practice seems to be beneficial when it comes to making the most of psychedelic experiences.
Yeah.
So, is this something that you think should be incorporated in borderline personality, in psychedelic therapy for borderline personality disorder?
Yeah, definitely. So I think when people, I think there are some studies, let's say with healthy participants, where you just give them, it's bare bones, you kind of give them the psychedelic and have some integration, but that's it for the most part. I think the research is bearing out that having that experience with mindfulness, so having higher levels of what's called trait mindfulness, or using them together is beneficial. So I think, especially when we talk about the idea of doing psychedelic therapy with people with BPD, I think it's a very important thing that it get integrated within a kind of full treatment package. So something that both allows people to develop a sense of trust with the therapist, and also something that helps them to integrate it and continue the therapeutic process afterward. Because whereas one psychedelic session might work, or there's good research to suggest that it works with someone with cancer-related distress, and you find maintained symptom reduction as long as 4.5 years later, I don't know that that's necessarily going to be the case with BPD, and my strong inclination would be that wouldn't be enough, that we really do need kind of full intensive psychotherapy alongside the psychedelic.
So if you look at most current psychedelic therapy clinical trials, phase 2 trials, the psychotherapeutic intervention is mostly quite minimal, right? We have 2 sessions, maybe 3 sessions of preparation. The patient has maybe seen their therapist 2 or 3 times, and then they're going to have already a psychedelic experience. Is this a feasible thing in psychedelic, or should it be possible in psychedelic therapy with BPD, or is it that, considering the difficulty that many of these individuals have with maintaining trustful relationships with people, or building trustful relationships with therapists too, that they might need longer, more sessions before a dosing session can take place?
Right. So I think it's a really important question. And I think that question is actually going to bear out in issues like depression as well. I think there's a tension now between wanting to make the most cost-effective kind of treatment, and at the same time wanting to have the best outcomes. And that's, I think, always going to be a tension. I think if you think about something like depression, while there are decreases over time, you do see a lot of the people, the symptoms do come back. So there's going to be a tension with any intervention. How much psychotherapy should there be? In the case of BPD, because of the complexity of it, the risk concerns, right? There are pretty significant risk concerns in terms of suicidality and self-harm. My strong inclination, and definitely the place that I think that the research has to start, is in more comprehensive treatment packages. So giving people what we know already works and adding on to it something like a psychedelic to see is there a synergistic effect and is it helpful? As we get the safety data there, you might start to trail back a little bit, and maybe what a psychedelic does is means you don't necessarily have to have a year of treatment. Maybe you can have 3 months of intensive treatment alongside psychedelics, something like that. So I think those questions are all unclear and uncertain at the moment. But I definitely have a strong pull toward safety. And so I think the best way to do it, at least at the start, would be to integrate it with a treatment package itself.
Right, yeah. I think also maybe like the kind of rigid standards within clinical trials where you have a set number of preparation sessions and then you have your dosing session, maybe that's not ideal for treatments of patients where the therapeutic relationship is maybe more fragile or more hard to build. So maybe it should be more the goal to maintain or to build a trusting relationship first.
Yeah.
No matter how long that takes.
Right. So I think that one interesting thing is that the majority of clinical trials with psychedelics have actually included for BPD. And that makes sense given the kind of context in which they're being given. And you're focused on depression. Maybe it makes sense to exclude people who are who also have additional comorbidities or additional risk issues. And also when you're providing such a small treatment, it makes sense that you might exclude people. But I do think that that kind of rigid RCT package is probably not the best way to explore psychedelics in the context of BPD, at least not at the start when you're trying to manipulate the variables to see what's the best way to do that. And like you mentioned, one of the important reasons for that is that there's this interesting relationship within psychedelic therapy where one of the things that we think psychedelics do is probably enhance your connection to your therapist and make you feel more connected. But at the same time, having at least enough of a connection and a sense of trust that you can allow yourself to let go and allow yourself to trust your therapist to administer this consciousness altering drug is really important. So I think, especially in the context of BPD, I don't think it would be responsible to have 1 or 2 sessions and then no matter what, administer the psychedelic. I think it is important that a relationship grow, that trust be established, and that only once the client and even the therapist think that there is enough of a rapport, enough of a trust to administer the psychedelic, that it would be appropriate to do it.
Right. Yeah, that makes sense to me. Although the paper or the study that you mentioned, the Brazilian study, the ayahuasca study, there was a study of treatment-resistant depression as well, as far as I know.
Yeah.
But they also included BPD patients, you said.
Right.
And that was a quite minimal intervention, wasn't it?
Yeah, it was. Yeah, it was quite minimal, especially compared to most of the psilocybin trials. I think it was really nice it was good that trial didn't exclude for people with BPD. I think what you end up getting is a kind of risk benefit issue. So we want to minimize risk to a population because we care and we want to make sure that they're okay in the intervention. At the same time, by excluding them from treatments, we might actually be preventing them from being able to benefit from these treatments. So one of the things that was nice about that one is that they didn't exclude for that. If if I were to be designing an intervention for people with BPD, I mean, one of the things there is that it wasn't for BPD. They just didn't exclude that. And it happened to be that because it was quite a complex population, there were lots of comorbidities and lots of different personality disordered individuals that were part of the study. But if we were trying to design an ideal intervention, especially one before kind of safety parameters have been established, I think I think it would be better that it be designed as a more intensive treatment package. And I mean, there are other ways to study it. You could look at people. One of the ways that we're looking at it is that people attending psychedelic ceremonies, so we can look at their symptoms before and after, and that starts to give us a sense of, are there any safety concerns? What does it do to their symptoms before and after? But at the same time, I still do think that if we want to have the best kind of treatment, it should be with more psychotherapy. And then I think over time, you kind of first establish efficacy, and then you go into cost effectiveness. So I think you want to have the best possible treatment and then start to strip down to see what's necessary and what's not, which is what's happening in the BPD world itself. There are trials looking at 12 months versus 6 months, and those start to tell us, okay, maybe we can offer less. But I think when you're doing something for the first few times, especially in a field like psychedelic therapy, where there is worry about if something bad were to happen, what would that say about psychedelic therapy? Would that interfere with other research happening? And the fact that in BPD trials themselves, even in the best intervention trials, suicides do happen. I think we have to be as cautious as possible when trying to explore that question.
Yeah, sure, yeah. So apart from suicidality, what are the main concerns? Or did you get any reactions from borderline personality experts, like concerned people who read your paper and said, "What the hell are you trying to say here? This is dangerous. We can't do that." Right.
So I would say some pushback. I think one of the main pushbacks was, we already have evidence-based treatments. Why do we need this? And I think that kind of falls under what we were talking about before, which is we have treatments, but they're not necessarily that great. I think people's concerns are might stem from two places. One is just not being familiar with the literature that seems to suggest that psychedelic therapy does shows promise in certain areas. And the second is an understandable and useful protectiveness. People know a certain population and are worried about them, any harm coming to them. So I think that makes sense. So yeah, I would say I did get some pushback, but I wouldn't say. But I think that does tend to happen when you are taking two areas where there hasn't been a lot of work done. And I think that's one of the reasons I thought the paper would be useful. Is we don't have the answers to these questions, but I wanted to kind of get the ball rolling of thinking about maybe this is something that we should be doing. And one of the things I often think about is what the baggage is of psychedelics. So if people aren't familiar with the more modern day research, or even with the older research, they think of, why would you give a drug to somebody that has substance abuse issues, right? So they might not be familiar with the idea that it seems to maybe help with substance use issues, and there's low risk of abuse. So I think that sometimes it's more just about familiarity with it. And there's just an understandable concern. And I share that concern. I want to say that I wouldn't suggest doing psychedelic therapy with an individual with BPD before we know what the outcomes look like. I'd say it's something that would be interesting and be important to investigate, but I get it in that I think we actually don't know yet.
Right. So we've talked today, we talked a lot about, by the way, I would like to ask the audience to ask some more questions using the Q&A button. We still only have a couple of questions there, so there's still a chance that your question might be picked later. We've talked about BPD more like from a deficit perspective. I mean, that's the obvious way of talking about mental disorders, but I think it's also sometimes worthwhile to look at the strength of people. Could you say, like, are there any particular strengths or resources that people with BPD usually have? And
Yeah.
Oh yeah, what are they? What are?
Sure. So I think that area is actually it's kind of like the issue with not investigating positive aspects of personality in general, but it's probably also an issue with BPD where you look at a population and you're specifically looking at what's wrong as opposed to what's right. I'd say there are a couple things that come out from it. One is a certain sensitivity that's there. So if you think about, some people might be very closed off from the people around them, uninterested in interpersonal relationship, or not moved by things. I think people with BPD and children that maybe eventually develop BPD have a certain sensitivity that's quite quite beautiful in a certain way, in the sense that they're very they're looking for that sense of connection. They are impacted by the things around them in a way that that they're maintaining openness and really care about the people around them and how they can maintain relationships. So if you think about the idea of, you know, we don't care if someone being upset about how a relationship is going or being bothered by it comes from a place of meaningfulness and a place of wanting to connect. So I'd say that those kind of areas of sensitivity and openness to one's experience, and also that sense of wanting to connect with others, is one of the more positive sides of BPD.
Right. So there's actually, I mean, since connectedness is such a central topic in psychedelic therapy as well, there might be a synergy there actually between BPD and psychedelic therapy. Maybe it might be that this propensity of psychedelic therapy to connect people with other people around them, with their own emotions, with values. Do you think this is something that could be particularly valuable for BPD patients, or maybe particularly easy to access for them?
Yeah, I do. I think, well, I'd say first that we don't know, but I think it's certainly possible. I think what you have with people with BPD is kind of a shifting between connectedness and disconnectedness. And so I think both the fact that psychedelic therapy seems to help with enhancing connectedness and social connection, that could maybe be something that would actually pull and be helpful for individuals with BPD, but also the fact that people are already coming in wanting that connection. I think that is something that is important.
Right. Yeah. So, like, coming to an end of this discussion, so what kind of research is needed before patients can be finally given access to psychedelic therapy, if it's helpful at all? I mean, what kind of studies have to be done?
So I think there are a few kind of levels or types of studies that can be done. The first is observational studies. So there are these people that are using psychedelics either on their own or in ceremonial settings. And some of them presumably have BPD symptoms or BPD. So one way that we're trying to look at that is looking at what is the impact on their symptoms before and after they take psychedelics. That's one level. Another level is to start kind of very basic with case studies, right? Take a few people, administer the kind of traditional interventions like mentalization-based treatment or DBT, and integrate a psychedelic within that treatment. One of the ways that we're trying to also look at that question of on a case study level is we're running a trial where we are integrating cognitive processing therapy for PTSD with MDMA-assisted psychotherapy. So not a classic psychedelic, but entactogen, something with similar potential maybe. And what we're doing similar to that Brazilian studies, we're relaxing the exclusion criteria. So maybe there'll be some people who will be a part of that study who then will give us some data on it. And then I think over time, the idea is to build towards something like an open label trial or a randomized control trial, with the maybe ultimate idea being contrasting your frontline, first line psychotherapeutic intervention for BPD with that plus a psychedelic to try to see, is it true? Do we get better effects when we administer psychedelics alongside psychotherapy?
Right. So it sounds like there's a long way to go still.
Definitely. Yeah, it's an area with lots of open questions, lots of uncertainties, and lots of I think important research that has to be done.
Yeah, sure. Yeah, I think this is a good time for another disclaimer that we do not endorse self-medication with psychedelics or underground therapies. I think this goes without saying, but on the other hand, we can't stress this enough that the fact that we're talking about it does not mean that you should try this at home. I think especially what we've said about the special needs of those patients in the context of psychedelic therapy already points to the fact that these needs may not be met in settings that are not controlled very well.
Yeah, absolutely. I would echo that. I think the idea behind the paper was to suggest that this is research that has to be done, but I think it has to be done in a very careful and very sensitive way. And I definitely wouldn't endorse that until that research is done, that it be used in those contexts. But I think hopefully that research does get done, and then we get some helpful data to help us answer the question of would it be useful to use psychedelics in the treatment of BPD?
Yeah. Okay, Rick. So we're approaching the end of the conversation part of this webinar, and I'd like to ask you a question that I want to ask every guest in the Zooming In webinar series, and this is: could you name one or two academic papers, or maybe books or book chapters, or movies or musical pieces, or any item that have influenced or enriched your views of psychedelics or psychedelic states, psychedelic therapy, and that you'd like to recommend to our audience?
Sure. I think there is a book and an article that I often recommend. The book is it's called Sacred Knowledge. It's by William or Bill Richards. He's been doing psychedelic therapy since the 60s, I believe. And it's just a really nice book that goes into what the experience is like, compares and contrasts it with different religious experiences and different religious traditions, and just sets up a certain phenomenology of the experience in a really nice way. Probably on the opposite side of that is about a paper that I found really interesting is Robin Carhart-Harris's Rebus paper. So I think the title is something like Relaxed Beliefs Under Psychedelics. And basically the idea behind the paper is it's an attempt at a unified theory of what psychedelics do and how they lead to change. And it's really looking to take kind of like leading neuroscientific models of the brain and integrate them with what we find under psychedelics, and as well as what we know about psychological change in general.
Yeah. So Bas, maybe you could post that paper too in the chat so that people who want to have a look can have a look. Thanks. Yeah, those are really great choices. Although I have to admit I haven't read the Richards book yet, but the Rebus paper I really liked, and yeah, perhaps it's a good dialectic to not only read the kind of hard scientific stuff, but also some more humanistic and spiritual literature. So I'm looking forward to reading that soon as well.
One of the things I love about psychedelic research is this attempt to both kind of go off into profound experience and at the same time to try to kind of pull it back and use scientific tools to make sense of it. And it's a kind of constant going back and forth for me. But it's really, I always appreciate having both people who are the more mystical type bent and also the more hard reductionistic attempts to make sense of what that experience is about and how we understand that from a neuroscientific or psychological frame.
Yeah, maybe you're right. Maybe that's one of the allures of psychedelic science in general. It brings together those two seemingly irreconcilable dimensions of human experience.
Mm-hmm.
Yeah. Okay. Well, Rick, I really feel like this conversation could go on for much longer, but I'm afraid our 60 minutes are over, and it's time for a Q&A. Let's have a look at the questions people have been asking. Can you see them?
Yeah.
Yeah. Right. If you see one that you like, let me know. I'm also looking through them now.
Okay. How much shame is involved in relationships to emotions for people with BPD? Sorry. So I should say the question is, how much is shame involved in the relationship to emotions for people with BPD? And I'd say that it's quite high. So shame is a pretty prevalent emotion for people with BPD. And that question is nice in that it's not just shame, but there is this kind of shame toward one's emotions. And that kind of gets into what we were talking about in terms of that acceptance piece, that instead of just having the emotion, there is this tendency to ridicule oneself or be hard on oneself because of those emotions. And that's where, Max, that what you suggested around that tenderness or that kindness toward oneself will likely be an important part of therapy in general, and something that psychedelics might be useful for.
Yeah.
Okay.
So I like the second one here. We talked a bit about preparation, but so here's Joas Mudde asking, what would aftercare and integration of psychedelic therapy for BPD look like? And how would it be different from the protocol for depression? So in the depression study, or in the depression studies with psilocybin, there's usually, also only 2 or 3 integration sessions, right?
Yeah.
And this is not a very psychotherapeutic intervention usually, but usually it's just talking about the experience and developing some ideas on how to integrate this into life. But it's really quite minimal as far as I understand.
Yeah, so it is quite minimal. Some of the more recent models, so Roz Watts has another paper where she basically formulates her model of taking elements of acceptance and commitment therapy and integrating them into treatment. And one of the components of that is this sense of identifying ways in which you might want to change your behavior. That's like the third element, but the problem is that there's not necessarily always time to get to that, and she notes that in the paper. So I think that one of the ways in which it would have to look different on an integration level is just the amount of time that's spent. I imagine that the experience can be quite challenging and difficult, and for people higher in neuroticism, we actually find more difficult experiences. So I think there would just be an importance of taking more time to process the experience. And that's one of those places that I think some of those kind of contemplative practices that we spoke about would probably be helpful. So within dialectical behavior therapy, you have a training in mindfulness. So I imagine that would be one of the ways in which it would be different, that you might want to have an intensive practice both before to prepare for the experience and afterward. And there's good research suggesting that when you incorporate some kind of mindfulness practice in a psychedelic intervention, that it is helpful. So that those are kind of 2 of the ways, kind of more of a focus on behavioral change. What can we do with this experience? How can we shift things in life? And also, what kind of practices can we use to take the experience and integrate it?
Mm-hmm. But you mentioned mindfulness practice again. Another thing that comes to my mind that is often a part of treatment of borderline personality disorder is skills training. So learning to reduce highly emotional states, learning to reduce dissociative states, states of high emotional distress. Is there a place for skills training in psychedelic therapy for borderline disorder? And could patients even use skills during dosing sessions? Does that make sense?
I think it does. I think a lot of what the preparation for psychedelic therapy sessions can include an element of mindfulness, which is one of the core skills of dialectical behavior therapy skills training, which is a piece of DBT itself. So I think it would play an important part both in the preparation and afterward. I think there are ways that I think psychedelic therapy would help, but I don't know that it would help everything. I think there are interventions that combining, I kind of think of psychedelic therapy as that kind of, Stan Grof said, like the hyper placebo. So the idea is that it can have a large impact, but what that impact actually looks like afterward is going to really depend on the frame and the context in which you provide the experience. So I think that beyond it just being the fact that you'd get dialectical behavior therapy's advantage and maybe psychedelic therapy's advantage, it really is an integration, because psychedelics, I think, are so profoundly impacted by the context. And evidence of that is, a lot of the earlier, we can both look at it on a lot of the earlier research didn't necessarily pay attention to that. And so you have these horrifying examples of people being, strapped to gurneys and kind of chained down and given a psychedelic, and it wasn't helpful. So I think that the context that you give it in not only ensures safety, but it is helpful for amplifying the usefulness of the experience.
Yeah. Well, thank you, Rick. Do you see any other questions that you find particularly interesting? I see a lot of great questions here. I'm really impressed by your audience here.
Any that come up for you? I'd like to look in.
Yeah, sure. So, for example, there's a good one here. So, which specific substances, in your opinion, is promising in treating BPD? You mentioned studies done on ayahuasca. What about MDMA, as it is effective to PTSD? And BPD oftentimes is correlated to trauma.
Yeah, so that's a really good question. I think the answer is that we don't know which substances. So I kind of, in that paper that we did, we drew a kind of a broad brush. We spoke about MDMA, classic psychedelics, and even ketamine. I think substances like MDMA definitely have potential. So BPD and BPD is not only associated with high rates of trauma in early lifetime, but a lot of people with BPD also have PTSD. So I would imagine that it would make sense to me theoretically, given what we know about MDMA, that integrating MDMA with interventions for BPD could be useful. Yeah, I think MDMA and psilocybin are the two that kind of come to mind. MDMA, I think, has certain benefits because of the quality of the experience can be a little bit less intense. So that makes me think that it might be useful. And then, yeah, and classic psychedelics, probably especially psilocybin, I think might be useful for kind of facilitating the process. But I think that a lot of what you might be doing there is targeting the trauma or is targeting the PTSD, and that's one of the reasons why psychedelic therapy might be useful in this context.
With MDMA, one thing that comes to my mind, or one potential caveat, is the MDMA is perhaps more easy to abuse compared to psilocybin. It is, although it's not really considered an addictive substance, it's much more likely, I believe, that people may develop a problematic relationship with this drug.
Yeah.
And yeah, maybe.
Sorry, keep going.
Yeah, and I think this leads us to the more general idea that one might think that if you introduce BPD patients to drugs such as MDMA or psilocybin, that it might just be another tool for them to inflict self-harm. Wouldn't that be a potential risk or a potential negative outcome of trying this?
So I think always worthy of being cautious whenever you're introducing any kind of substance. I think the data on what happens after these kinds of therapies will be very useful for this. So far, the small research that has been done doesn't suggest that people after getting MDMA assisted psychotherapy abuse the drug or even use it in non-therapeutic settings. So there's one study of MDMA assisted psychotherapy where they followed up with people a year or two later, and they found that there was maybe one or two people that did, but they had used it in a kind of a therapeutic setting, and were not abusing it. So that is helpful. Given that that wasn't a BPD context, I think it remains an open question. Um, I think I agree that one of the benefits of psilocybin is that it has much less abuse potential than MDMA. And that's also one of the reasons why I'm especially cautious about something like ketamine therapy for BPD. It's not that I don't think it has potential or couldn't be useful. It's actually, there's a trial going on now using ketamine for treatment of BPD. But I think if we're looking at the question of concerns about abuse or harm, I think ketamine is one where that is more significant, both because of its physiological effects and what seems to be the data about how long it lasts. So whereas with MDMA and psilocybin, it seems to last weeks to months, maybe even longer. With ketamine, you might see a trailing off of effects in other disorders within days or so. So, or maybe weeks, but it's just not clear. So I think, being cautious about that is really important. At the same time, it's always a risk benefit calculation. So is it possible that some people might end up using a drug or even abusing it? It's certainly possible. But that person might also be abusing other drugs anyways. And at least maybe this intervention could be useful. It's not an important worry, but I think if it stops us from actually doing the research, I think that's problematic, especially when you think about what current trials for BPD and general practitioner use are. So, we have people prescribing barbiturates, anti-anxiety medication to people with BPD pretty frequently. And those have very strong potential for abuse and for serious harm. So worth being cautious about, but also maybe not too cautious so that we can't even do any kind of controlled studies where we look to minimize those potential harms.
Yeah, right. So there's actually a lot of, that's not surprising. There's a lot of questions here regarding risks of this treatment. And I really appreciate that our audience is risk aware. Here's one from a dear colleague, actually, Ricarda Evans. What are your thoughts on serious side effects and risks in psychedelic therapy in BPD? How to assess risk-benefit ratio in planning a study? Like what requirements should be met by patients before entering the study?
Yeah, so that's a very good question. I think where you want to start out being especially cautious. So in our paper, we actually suggested that people with recent serious self-injury or suicide attempts should be excluded. So that was one thing. We also suggested that maybe doing this therapy in a context, in an especially controlled context, like some interventions for people with BPD are in an inpatient context. So I don't know that has to be the case, but those are some things that I think would be important at the start. So you don't necessarily want to have someone who's, while you might think that at the end of the day it could be useful in those contexts, I think the place to start is definitely, like with all pharmacological interventions for BPD, by excluding the most severe. So if we get a signal in the less severe population or the population with less, let's say, risk, then you might extend it to other populations. But yeah, so I think both paying good attention to who gets into a study, ensuring that we don't just give the drug just because they've done 2 preparation sessions. We ensure that rapport is established. And yeah, using psychedelics alongside kind of an efficacious intervention that we know is helpful for maintaining and minimizing suicide risk, I think is also important.
Yeah.
But it's a really good question.
I suppose that's already a kind of a way of excluding particularly difficult or patient populations that are unlikely to benefit from psychedelic therapy, is to make it compulsory to be in a treatment that is ongoing.
Mm-hmm.
Just the ability to stay in the same treatment for 10 weeks or something like that would already be quite a high bar to pass over.
Yeah, I agree. It would make it would ensure that you have to have at least some kind of therapeutic rapport, some sense of the therapist believing that it will be appropriate at this time and safe to administer the drug. I think having these kind of limitations is really important, especially when you are talking about something that has risk, in the sense that, like I said before, even the best trials using the most efficacious interventions we have see suicides, unfortunately. So I think, especially given the history of psychedelics and the potential for, things could go in any direction, I think we do want to it is important to be cautious and make sure that we minimize any kind of risk. Yeah.
So here, one last risk question here. So here's Tobias asking, Rick, you mentioned at the beginning of the talk that patients with BPD sometimes experience mild levels of paranoia during episodes of intense emotional dysregulation. In the context of psychedelic-assisted psychotherapy, do you have any thoughts on the potential risks, specifically with regards to the occurrence of psychotic episodes or paranoid episodes in that patient population?
Yeah, I think that's a really good question. I think it's important. There is this, so most people with anything like psychosis or schizophrenia have been excluded from all studies because there is this worry about it triggering something along those lines. So on that note, I do think it's important to distinguish between the kind of mild, transient, kind of like almost psychotic-like experiences that people with BPD have versus psychosis. They have maybe some small similarities, but they're not quite the same thing. And they're mostly born out from extreme emotion dysregulation in a certain context that then triggers mild paranoia. I still do have concerns. And so I think that the way to do that is to both look at case reports. So trials where people have been given BPD, does that happen? Are they still safe afterward? And also reports from people that have used it themselves to see, does this happen? And if people do have that kind of experience under the influence of a psychedelic, is that harmful to them? Does it last? And so I think important to be cautious and to pay attention to those details for sure. But I'd also say we just don't know, unfortunately, whether or not it has that effect in this kind of population.
Yeah, this also is related to the question of special needs of BPD patients in psychedelic therapy. Perhaps it's especially important for this population to have the well-established therapist diet, like a man and a woman, and also agreeing on boundaries for physical touch. Do you have any thoughts on that? Is that particularly important in this, or should there be different rules in this patient population?
Yeah, I think it's important to think about those. I think there has to be much more preparation and discussion about what's acceptable versus not acceptable. I think in the context of current trials, I think it's very useful that everything is recorded, so that if there is concern about touch, you at least know, what did we agree upon? Was it within that realm? But I do think that it is worthwhile to be wary of how might that interplay in this specific population. And so I think we need to take the best of the science of both worlds, the best of what we know about psychedelic therapy and the best of what we know about BPD treatment together. And I do think that that attention to detail, especially on the therapeutic relationship, is going to be especially important. Both so that it can be helpful for the therapy itself, the psychedelic, and also so that in the session itself, people feel like they can trust the person that they're with. Because if they can't, I don't know that the psychedelic session itself is necessarily going to be at least not as helpful as it could be.
Yeah. So maybe you have time for one last question before we close for today. So here's an anonymous spectator asking, in addition to the clinical studies, have you found any valuable written accounts of psychotherapists that have used psychedelics with their BPD clients, either accounts from before the current prohibition or current underground therapeutic use?
Yeah. So I'd say one of the things that we did in order to try to understand what do we know and what do we need to know is we looked at all the old case studies and all the old examples. One of the things we note is that Peter Gasser, who's a person who's been doing legal research with psychedelic therapy, mostly with LSD, he notes
in Switzerland, we have to say, right? He's the only, or he has long been the only person in the world who can legally prescribe LSD to patients.
Right.
Yeah.
So, which is, it's incredible that he's been able to do that throughout this time. And so that's a wealth of knowledge because the BPD diagnosis wasn't really given until later. So the two things that we can note is that people who had symptoms that we might say are similar, and also his description. So he notes that that there were a lot of people that had what we would call borderline-like type features or borderline personality disorder that came for treatment, and that he thought it would be helpful. So that's not necessarily empirical data to support it, but it at least gives us a sense that a clinician who's been doing this kind of work for a long time also feels similarly that the people that he's treated who have kind of met this or have been close to this kind of category seem to have benefit from it. And I think that that's a promising note and something that tells us, okay, maybe there is something to be explored here. In terms of reading accounts of current therapists that have done it, I have not. One of the things I have done is our paper was posted on Reddit boards. And so I found it fascinating to read Reddit boards of people who were responding to it with their own experiences. And some people, I could note a couple instances where people said they actually thought it wasn't helpful for them, but that they also did it in an uncontrolled context, and that might have contributed to it. And other people who thought that it was very beneficial and very helpful to them. Again, that doesn't necessarily tell us that this is that it's going to work, but it does tell us that if there are people that have been using it and have been doing it not even in a therapeutic context, and they've found it to be helpful, that maybe there's something about the experience or something about the pharmacology itself that could be useful for treatment in this population.
Well, Rick, thank you very much. I think it's time to say really thanks to everyone in the audience for attending. Thank you all for your really stimulating questions. I'm always really impressed by your audience here. This has been great fun, and thank you, Bas, by the way, for holding things together in the background. Great job, Bas, and of course, thank you, Rick Zeifman, for having this conversation with me and for answering those questions. And I hope to have you back someday. Would you be up to doing this again someday?
Absolutely, let's do it.
Great,
no, this was great. It's nice to have an interest in an area that there aren't that many other people in my world, let's say, that are doing research in this area. So one of the things that's been nice with the paper and with these kinds of things is getting emails from people who have that kind of overlapping interest in BPD and psychedelics. So it was great to have the opportunity to chat about it and hear everyone's questions. And thanks for facilitating the conversation.
Well, thank you, Rick. And before saying goodbye, I'd like to say to the audience that there will be more Zooming In webinars in July with very exciting guests and topics. We will inform you about these.